Hi, I'm Garrett Hyman from Lake Washington Sports and Spine in Bellevue, Washington, and I'm going to talk about some dynamic scanning of the knee joint. So we have here Jacob, our model. He's in a seated position. This is ideal for looking at the suprapatellar recess of the knee. So first I'm going to take this probe, which is a 6 to 15 megahertz probe, linear array. I'm going to use copious gel at the anterior knee. And I'm going to start by looking at the suprapatellar recess. If you look at the right of the screen, you see the bony hyperacoustic landmark of the patella. So that's the superior pole of the patella. Beneath that, there's a bony hyperacoustic landmark of the femur. And then superficially, after some skin and fat, we have the quadriceps tendon. Quadriceps tendon has nice, tightly packed fibrillar architecture, and if I follow that distally into its insertion, or the enthesis at the knee, we can see that enthesis at the patella. Looks terrific. Beneath that quad tendon, there's a fat pad. Beneath that is the joint space, and there is a very small effusion in this knee. And then there's hypoechoic hyaline cartilage on top of that femur. I'm going to scroll laterally or roll my transducer laterally, where now I can see over the lateral femoral condyle, I can see that hyaline cartilage quite well with a hyperechoic line just over the top delineating the anterior portion of that hyaline cartilage. So now I'm going to come back to the center view, where if I now compress up and down, I can see that small effusion displacing, but what doesn't displace is the anechoic hyaline cartilage. What another structure is displacing, in addition to that effusion, that would be the fat pad. Okay, so I can displace that with this pressure. I'll roll now to the opposite side of the knee just to look at the cartilage overlying the lateral femoral condyle. And so I have to tilt the transducer to try and tune that in. I'm going to turn the transducer now into a transverse plane. So now to the left of the screen is going to be lateral. To the right of the screen is medial. So right now I am scrolling back and forth. I'm going to try and find my best view right over that femoral trochlear groove. That femoral trochlear groove, we can see that hyperechoic bony acoustic landmark of the femur with posterior acoustic shadowing. And just above that is anechoic hyaline cartilage. There's a small cartilage interface sign right there with a hyperechoic line. And as I come a little more proximal and in the center to lateral portion of the screen, there's a small effusion in the joint, very small. And that might be physiologic joint fluid. And superficial to that, or anterior to that, is the quad tendon. Again, I can just quickly orient myself by scrolling quickly proximal to distal to look at that quad tendon, get back down to the femoral trochlear groove. So now I'm going to do some of that compression that I did before, but now I'm in a transverse plane. So now if I compress, I can either displace an effusion that's there, and or I can actually watch the fat pad there. Here's the fat pad in transverse that's displacing as I press it. So this is very useful if you need to delineate that joint capsule and separate it from both the fat pad, separate it from the hyaline cartilage, because we often try and access the joint procedurally at the suprapatellar recess. All right, and again, I'll flip into this longitudinal plane and again show you what happens as I compress, and which displaces either fluid and or the fat pad. What doesn't displace is that hypo or anechoic hyaline cartilage. So that is the dynamic view for the suprapatellar recess. So let me show you some dynamic motion. If I passively extend the knee and flex the knee, and I try and maintain my probe right over that femoral trochlear groove, this is a nice view. So we can see that just beneath that quadricep tendon, there's a pouch a pouch of anechoic fluid that pops up. So as I extend the knee even further, we can see that move. We can see the fat pad move as well. And this really helps us to delineate the confines of the joint capsule. That's a nice view. I'm going to turn the probe into a transverse plane. We're going to do the same thing. And I'm going to try and maintain the probe over that femoral trochlear groove as I do that. And that looks very nice. Now I'm going to show you the medial joint line, and we're going to do some dynamic scanning after showing you the MCL. So Jacob, if you could now turn your body so the inner knee is face up, that is terrific. This is great. I'm going to make sure I have enough gel at the medial joint line. I'm going to show you now the MCL first statically. So let me come up the most superficial view that I can. Now to the left of the screen is the medial femoral condylar attachment of the MCL. The MCL here is nicely shown. We have hyperechoic fibular architecture of the MCL. Again, the bony acoustic landmark in the screen is the medial femoral condyle. I'm going to scroll down the MCL, and I'm at the joint line now. So just beneath that MCL at the joint line is the medial meniscus edge. And the MCL does have a superficial and a deep portion. The deep portion has an attachment to the MCL, which is why people often get both MCL and meniscus tears together. I'm going to scan now that MCL distally, and what has always been interesting to me is just how long that MCL actually is, and you'll see as I scan all the way down to this medial tibia, the terminal end of the MCL is quite distal. And I'm going to come back up proximal to that joint line. So now we can see the MCL. Again, let me tune in that, that's a nice view. We can see the fibular architecture, and we can see the meniscus as well. Now, Jacob, I am going to apply a little bit of stress because I have him in a position where I can nicely apply some valgus stress to the knee, which if he had a tear, I might see separation of the two edges of the, to the left again, the bony acoustic landmark of the femur, and the right is the tibia. And if he had instability at that medial joint line, we might see separation of those bones with valgus stress. But we don't. His MCL is nicely intact. We can see that meniscus quite well. It's got, it's relatively hyperechoic compared to his, and it doesn't have the same fibular architecture as does the MCL. We can see that. I don't see any clefts. Now, actually, this type of valgus stress could be useful. This is more of an advanced skill, but if there was a question of a cleft in that medial meniscus, this type of stress might accentuate fluid traveling through a cleft in the meniscus. So that is terrific. That was a nice view. We could, should we want to, we could look at the MCL also in transverse, but we're really not going to do a dynamic image in transverse. So that's all I'm going to show you right now for dynamic imaging of the knee. Go out and try it yourself.